neurological impacts. And we're going to have a discussion today among a team of experts. And we're going to take a minute now and just have each one give a brief introduction. And then we're going to go chronologically through a set of studies that have been done, starting with the original one in April of this year, moving now into December. But I want to begin by welcoming some of the top people in our nation who are on the front line dealing with COVID-19 and dealing with the interaction with this virus as it relates to the central nervous system in the brain. So Dr. Katab, first of all, let me welcome you. Let me thank you, my friend, for all the work that we've done together over these many years. But let me introduce you and have you talk a little and introduce the panel, have each person on the panel introduce themselves, and then we'll get right to work.
Yes, Congressman, thank you very much for your time, and thank you very much for putting this great briefing together. This is Babak Kateb. I'm chairman of the board for Society for Brain Mapping and Therapeutics. With us, we have our colleagues from different universities who have currently patients with COVID-19 and have been dealing with the neurological and psychiatric as well as pulmonology aspects of the COVID-19. So with that, I would like to ask from Dr. Vicky Yamamoto from USC Tech School of Medicine quickly introduce herself.
Hello, hi. Can you hear me?
Yes.
Okay, great. Hi everyone, this is Vicky Yamamoto. I'm currently working as a research scientist at the USC Keck School of Medicine and at the Norris Cancer Center. So my background is I have a PhD in stem cell research as well as a neurodevelopment. And currently I'm working on basically in head and neck cancer research. Our aim is to try to enhance the radiation and chemotherapy sensitivity. And I'm also serving as SBMT's executive director and also one of the founding members of the society.
Thank you. Dr. Ambush Tiwari.
Hi. Hello.
Hi.
Hi. Hi. My name's Dr. Ambush Tiwari. I'm part of Department of Neurology and Neurosurgery and Radiology at NYU School of Medicine. I basically deal with stroke care and stroke intervention of patients, and we, along with the SBMT team, were one of the first people to report incidents of stroke in COVID from New York City.
Excellent. Dr. Don Eliasha from UCLA.
Hi, I'm Dr. Eliashiv. I'm a professor of neurology at the David Geffen School of Medicine at UCLA. I work at UCLA Medical Center, and I've seen many patients both in the ward and in the intensive care units that are infected with COVID-19, as well as some of the patients with sequela.
Thank you. Dr. Ashraf Al-Sayed from Cedars-Sinai.
Hello. Thank you for having me as part of this panel. My name is Ashraf Al-Sayed. I'm an MD. I'm boarded in pulmonary and critical care medicine. And yes, I'm affiliated with Cedars-Sinai Medical School. I'm sorry, Cedars-Sinai Health Center. With my specialty of pulmonary critical care, I'm obviously on the very front line of COVID-19, dealing with many patients on a daily basis. So looking forward to all of this.
Thank you. Dr. Tim Cushing from Cedars-Sinai UCLA Rehabilitation Center.
Hi, folks. Yeah, my name is Tim Cushing. I am a physical medicine and rehabilitation doctor based out of California Rehab Institute in Los Angeles. Main portion of my practice deals with orthopedic rehab. However, as the pandemic came on and we started noticing this need, we began to bring a lot of patients into our acute inpatient rehabilitation ward for care. And so I've absorbed a portion of those patients coming in and provided the rehabilitation care or overseeing the rehabilitation program. Thank you.
Excellent. Dr. Rebecca Hendrick from Cedars-Sinai.
Yes, so I'm the Director for Consultation Liaison Psychiatry here at Cedars-Sinai. So I see patients in the hospital wards and in the emergency department who have COVID or who've recovered from COVID that have psychiatric issues. I'm also the Vice Clinical Chief and an Assistant Professor here.
Excellent. We have Dr. Joe Bolanos, who's a fellow of Society for Brain Mapping, together with Dr. Vicky Yamamoto. They published the landmark paper on COVID-19. We have a group from University of Kentucky, our colleagues at University of
Kentucky Neuroscience Institute.
Yes, Kentucky Neuroscience Institute. Dr. Amy, are you there? Can you hear us?
Thank you so much for this.
Your voice is coming very patchy. If you speak loud and close to the microphone and have your group introduced, that would be great.
Okay, I can be loud. I'm a mother, I can be loud. So thank you so much for having us. I look forward to sharing a case that we've encountered of the long-term sequelae of COVID. So I just wanted to introduce my team. So Dr. Fawad Yusuf is a PGY4 resident in his last year of training. And then my colleagues, Dr. Richard King and Dr. Timothy Ainger, will be sharing this case with you. We're excited to be here with you.
Excellent.
Thank you. Well,
All right,
thank you.
Congressman, the floor is yours.
Well, thank you. We're going to move through a number of cases, and I'm going to start with a young man who's 24. He's in Japan, and it's February. He gets sick, and he visits a doctor on day 2, and they treat it as if it's a normal case of the flu. But on day 5, he reappears. He's sicker, and he's not getting any better. Day 9. His family finds him unconscious and laying in his own vomit, and he's having seizures en route. And this case is written up. Tashiki Morichachi writes this case up, and it's published on April 3rd. And he focuses on the neurological impact of COVID. And what I'd like a couple of the people on the panel to respond to is, in retrospect, what was missed from the early signs of this case in terms of how we've interacted with COVID-19 patients, literally millions of them since then?
That's an excellent question. Dr. Eliashev, you see a lot of cases, neurology cases. So Dr. Ambush Tiwari, if you could comment on this.
Yeah, I mean, I think that, hindsight is 2020.
Yes.
But I think, it's known that a lot of viruses, there are olfactory symptoms, but I think the olfactory symptoms, loss of smell, has been more common in patients with COVID-19, even though it's been shown in different disorders. I think that what we missed in general is like applying more early diagnosis, early screening in the early phases of the pandemic, and underestimating the R and the degree of spread between asymptomatic patients and symptomatic patients. So I think that those were things that were missed.
Excellent.
And the other thing is like having the whole plethora of like emphasizing the respiratory illness rather than looking into all the other multi-organ symptoms, including neurological symptoms that may be mild to begin with, but are very prevalent, maybe prevalent. So those are the things that have been missed. A lot of the neurological.
Thank you, Dr. Tiwari. Thank you very much. Dr. Tiwari, you are on the front line in New York, and you receive a lot of patients and treat them. Your thoughts?
Yeah, so for us, it was interesting. We actually started seeing a huge incidence of stroke around the last week of March. The shutdown started around 16th of March. We started seeing a sudden incidence of increase in stroke from the last week of March. And the interesting thing that we found was in one of our cases, actually, in fact, it was a case that I operated on, came out in New York Times about this EMT, where the first real presenting symptom of COVID was the stroke itself. So what we realized was that a lot of people would end up having an immune response, which was so severe that their immune markers would go up. But instead of the immune markers showing as a respiratory illness, it would trigger, and this is a known mechanism. It's seen in antiphospholipid syndrome and some other, cancer-related strokes, where the body's immune response triggers a mechanism which causes strokes from happening. And that sort of resulted in our numbers went up, like we were showing a 200% increase. And we were the first ones to sort of shed light on the fact that stroke could actually be a presenting symptom, that even though your respiratory illness is sort of mild, it's the extrapulmonary symptoms which can be so severe that it can be the first sign. And I think from May onwards, all our New York institutions, as a universal protocol, started testing any patient and every patient who presented with stroke for COVID. So that was sort of the new thing that we found. And then other people also found the same thing with the heart and lower extremities and other places. So thrombophilic events was a major thing that we found with these cases.
Doctor, let me add this other paper into the discussion. Then on April 28th, we see another study that comes out, and it talks about delirium among hospitalized COVID-19 patients, and they lay out that it's almost like a delirium factory when we have so many patients and they're isolated from their families. They can't have normal even interactions with people like yourselves on the front line in terms of interacting. And but the virus is causing acute brain dysfunction in a way that is affecting people. And so that's an April 28th review. And I think what's important there is to think about, given the fact that we now have another surge, I'm assuming that there's been a lot of changes in the practice of dealing with hospitalized patients to try to avoid some of the neurological complications that come from just being hospitalized in ICU.
Well, that's a great point. Dr. Rebecca Hendrick from the Department of Psychiatry at Cedars and Cushing. If you don't mind, could you please comment? Dr. Hendrick, you can go ahead.
Yeah.
Yeah. Yes. So absolutely, delirium is incredibly common. It's up to 11 to 20% of patients with COVID will develop delirium, which we can also consider as acute brain dysfunction. Typically, one of the best treatments for delirium to help pull patients out of it quicker is to have family at their bedside. And this isolation, not only from family, but also, like you mentioned, from hospital staff, can be quite deleterious on the patients. I think it's a struggle that all the hospitals around the world are having with balancing increasing human contact, but also minimizing exposure to the staff. But yes, this does increase risk of anxiety and even post-traumatic stress from the intensity of the delirium and the social isolation. They've even shown studies that loneliness and social isolation can be as damaging to your health as smoking a pack of cigarettes a day, or as damaging as being morbidly obese. So these are, it's a tough time.
Thank you. Dr. Cushing?
Yeah, thank you. So, was that Cushing or somebody else?
Yeah, Dr. Cushing. Go ahead.
Okay, so in my practice, in our setting, we don't see a lot of the acute delirium because the patients have generally been discharged from ICUs and have been medically stabilized by the time that they come to us in acute rehab. But I mean, we are seeing a lot of the more long-term cognitive effects here in patients that are even young, otherwise healthy, normal working people. And we'll see these long-term cognitive issues. I mean, particularly in areas of memory and attention, problem solving, and so forth. And these things have a lingering effect as well, and really do impact the patient's ability to get back to a normal life and get back to their typical employment, things like that. So those are some of the problems we're seeing in the more kind of drawn out side after in the rehab process.
Thank you. Dr. Elias, a very short comment if you have. Go ahead.
Yeah, just very short. I think that what we our threshold now, and actually we're seeing now 2-3 times more patients now in this surge than we did in April. But our threshold for imaging of the brain, looking for vascular abnormalities, and also for continuous EEG monitoring, looking for subclinical seizures in the ICU setting. So what we're doing now is proactively monitoring a lot of these patients that we didn't monitor before. And delirium, we see delirium, and we see also subclinical seizures.
Excellent. Congressman, back to you.
Doctor, let me jump in. So the Global News did a story yesterday focusing on, in part, on a young lawyer from Atlanta who is one of what we now refer to as a long hauler, and has had these cognitive issues around the use of words and being able to function professionally. And she was quite, straightforward about the challenges that she faces. So this is a big issue, and obviously the concern about whether this is a kind of forerunner of acute dementia, or acquired dementia, is important. But I have to move to the next study, because before we can get into a full range of discussion, I want to get all of these things out there. So we have this next study comes along in June, and it says that an early sign of the COVID may not be respiratory. And, it may be that the attack on the central nervous system is the earliest sign of COVID, and they may be otherwise asymptomatic. And, I know that you see this, but the question is, do families and who are waiting to feel a flu-like event in their lives to be concerned about COVID, are there other signs that should raise concern?
Great question. So let me start by asking Dr. Ashraf Al-Sayed from Cedars-Sinai to respond, then we go to our colleagues in University of Kentucky.
Yes, thank you. So, being a pulmonologist, the majority of the patients that end up coming to me are pulmonary in nature. However, I'm seeing many more patients in the hospital now that have minimal or sometimes no pulmonary issues that come in with COVID. And one of the biggest problems that occur are GI issues. So that's another area where a lot of these patients present with COVID and just pure GI issues and not much respiratory. At the same time, as several other panelists have mentioned, there is a huge neurologic presentation as well. And Congressman, just as you said, as we're learning more about it, as we're picking up on more patients that don't come in necessarily with respiratory symptoms, unfortunately, the families and the general population is not aware of this. So every one of my patients, and I get many phone calls, are I have a cough, I feel a little short of breath, should I rule out COVID? But I never, patient or the general population does not think, well, I have GI issues, I have diarrhea, my stomach hurts, should I rule out COVID? Or I'm having neurologic symptoms, they're a little bit more confused than their normal baseline, should I rule out COVID? That's still not in the front of people's minds right now as much as it is respiratory, unfortunately.
Thank you, Dr. Al-Sayed. How about our colleagues in the University of Kentucky?
I'm Dr. Richard James. I'm a behavioral neurologist. So I see people that have memory loss, every week in my clinic. The symptoms that they're showing are very interesting, but are also very non-specific. And so it is difficult to know for any individual coming in with those symptoms, whether it's related to COVID or not. The big difference that I'm seeing, though, is the rate of onset. So for many of these folks, the memory and cognitive symptoms are developing and progressing much more quickly than we might expect compared to, say, someone who has Alzheimer's disease, for example, which is usually a much slower process. And so I think getting screened for cognitive issues is a really important factor. And having people be aware that this can be an early herald is really interesting. So, yes.
And this is Dr. Timothy Ainger. I'm a clinical neuropsychologist, and I get referrals from Dr. King all the time. And I want to echo his sentiment. And what we're seeing on testing is not only that rapid onset of symptomatology, but also that they are not relinquishing with standard treatment. They're not following standard progressive patterns, but also that in standard bedside screenings without an in-depth eval, sometimes people look ostensibly normal, and we need to rely upon a deeper testing modality that can dive further into what makes up complex memory, problem solving, and executive functioning, because the family will have complaints that they're unable to do day-to-day activities, but when you give them a brief cognitive screener, they may be able to pull it off to a certain extent.
Well, this might be an excellent moment, Doctor, to go to the Kentucky case, just for a few minutes, to at least allow an understanding of some of these challenges, even after COVID and testing negative. They have a case that is quite interesting. So why don't we detour for a minute and just let that be presented.
Excellent. I think Dr. Hessler would be happy to narrate that case for us. And we have 3 slides prepared if you can give us some screen sharing capability. Otherwise, we can do it.
I'm going to give you that, and I'm going to give you 3 to 4 minutes to get through it.
Perfect.
We got this.
Excellent. So while you're doing that, Congressman, Society for Brain Mapping and Therapeutics is advocating for the brain screening, like prostate and liver and kidney screening. And we are hoping that together we can advocate this in Biden administration.
You know that we're not here to talk about the problem. We want to focus on solutions, but we need to get through we need to get people to understand that this is a challenge that relates to COVID, that there are neurological impacts, and that the facts back that up. So let's walk through this case.
Sure.
Okay, this is Amy Hessler. So I just want to give everyone on the panel an overview of our patient. So this is a 60-year-old, healthy, highly functional healthcare professional. So he was hospitalized for COVID-19 pneumonia for 16 days, the end of March, beginning of April. And then he was re-hospitalized in June for acute behavioral and psychiatric changes and childlike behaviors. So the best examples I can give you of his childlike behavior, his 90-year-old mother was in a wheelchair and he was running with the wheelchair. And his son brought over a pizza and he was shoving all the pieces of pizza into his mouth. And then when his family told him to slow down, he spit out the food and ran away from the table. No other causes were identified. So there's metabolic imaging was abnormal, and we thought that he had an autoimmune encephalitis. He had neurocognitive testing that was abnormal. So what we did is we did baseline neurocognitive testing that Dr. Ainger will cover in a minute. We treated him with intravenous gamma globulins for 5 days, a standard course, and then repeated his metabolic imaging. And his neurocognitive, as well as that metabolic imaging, was improved. Unfortunately, he was unable to return to work and retired early from his profession. But he had improvement in paranoia and behavioral changes, but that was not sustained. That lasted only about 3 months. And then he was readmitted with continued functional problems. And his neurocognitive testing still highlights a decline from his baseline. But interestingly, his metabolic imaging was normal. So we're going to next go to my colleague, Dr. Richard King, to talk about the metabolic imaging.
So we were looking at trying to figure out what was causing his symptoms, despite a number of very aggressive testing. For example, looking for COVID in his CSF, it was negative. Looking for abnormalities in metabolic tests, they were negative. The test that came back abnormal was something called a phosphate emission PET scan. So this is using glucose as our label. This glucose molecule is the primary source of energy for the brain. So what you're looking at on this slide are two horizontal sections that show the uptake of that glucose molecule. And so the bar there on the top, the more towards the red side, the more uptake, and towards the blue side is less uptake. What you should see is a nice rim of kind of reddish orange around the side. This patient on the first scan on June 16, 2020, had areas of very, very active uptake, much more so than normal, as well as other areas of decreased uptake. And this combination of hyperactive and hypoactive simultaneously is what gave us the thought of the autoimmune encephalitis. He got the IVIG, and then the scan on the right shows that many of those areas of hyperactivity went away.
So what this looks like functionally, when we did our initial bedside neurocognitive evaluation, on the screen, that data is in blue. The green line that's horizontal across the top is his pre-morbid functioning line, and the red horizontal line is the clinical threshold for severe impairment. So on June 19, that initial neurocognitive showed scattered deficits, some of which were pronounced at a statistically incalculable level. And they were so pronounced across the entire functional area of the brain that it's beyond the clinical correlation that would be consistent with an Alzheimer's dementia, and more instead consistent with an acute inflammatory process. The lines that are in red, and those dots in red, are the 5.5-month follow-up neurocognitive evaluation that show there may be some slight improvement over the course of the healing process, but nowhere near a return to baseline, and could arguably be made the case that this is another long haul presentation where he's beginning to show some slight improvement, but is still nowhere near back to normal and is functionally around the level of impaired.
All right, well, what you left out is the part that, because we're trying to make sure people actually understand, what the interaction with his 90-year-old mother and the pizza episode, I think makes it abundantly clear that this normally functioning physician ended up, because of COVID, with clear neurological challenges.
This is an individual who, before he got COVID, was again functioning as a medical professional. And now some of the practical reflections are he cannot follow directions to empty the trash cans around his house.
He also was a master electrician, not just a good doctor, right?
Correct. He was also a master electrician and a handyman.
All right, now we're going to have to move on. So is there anything else that needs to be said on this case before we get back on schedule? Because I took this deviation because I thought it was important.
Thank you.
All right. I want to go to study number 4, which looked at the question of prevalence. Are we talking about 1%, 2%? Is this an isolated situation? Or when we look at millions of people who've been affected by COVID, and whether they're severe or moderate, what number of them, what percentage of them are going to have a neurological dysfunction, in this matter, because of COVID?
So Dr. Ambush Tawari actually wrote a paper on this. So Ambush, do you want to make a comment on the prevalence of neurological disorders?
So in our experience, at least in terms of the hospitalized patient that we had, we found the incidence to be about 1.5 to 2% for neurovascular events in patients who had COVID. But our experience specifically dealt with hospitalized patient and the incidence of all the stroke patients at that time. We did feel that there was a slightly increased population of stroke cases in the younger age group, which was less than 50. We've published 3 to 4 papers about that, and also a slightly higher incidence in specifically African American ethnicities in our cohorts, which included about 25 centers across the country. I cannot speak specifically to the overall neurological event because most of my research was to do with neurovascular events. So, I mean, maybe one of the other panelists could take the overall neurological events question, but I can answer for the neurovascular events.
Okay. How about Dr. Eliashev or Dr. Hedrick? Your thoughts?
I think it's the percentage is about right. I mean, when you talk about objective criteria that you can measure, like strokes and like vascular complications and seizures, there are some peripheral complications too. But there are also non-specific symptoms. The prevalence of non-specific symptoms is much higher.
Is this what we refer to as brain fog?
Could be, yeah, could be the brain fog, fatigue, depression. There are lots of other symptoms, and then we see that also in patients that have other neurological diseases, like a history of strokes or epilepsy. We see an increase in the manifestation of their symptoms.
Additionally, patients who had pre-existing psychiatric illness, almost all of my patients who've had pre-existing psychiatric illness have gotten worse, have had an exacerbation of their major depressive disorder, bipolar disorder, schizophrenia, post-traumatic stress disorder. They all have had worsening symptoms during their COVID infection.
Dr. Bolanos, did we report any statistics on our paper in the COVID-19 comprehensive review on this?
Yes, we have a table that starts the neurological symptoms. Back in August, this was really novel to think that neurological symptoms were actually really pinpointed to COVID-19. However, more and more you can find research and articles that are saying that what we had in our paper really was spot on when we reported it. So yes, those symptoms are increasing. You know, the first ones, anosmia, ageusia, were the first ones to be reported, and then some even say encephalitis, aphasia, and so on. So yes, we do have those.
Thank you. Congressman, back to you. Congressman, we are back to you. So I think we probably lost Congressman Fattah. So the paper that we're talking about is the COVID-19 pandemic review that was published in the Journal of Alzheimer's Disease. Congressman, go ahead.
Well, now I want to go to paper number 5. And the question here, which we touched on a little bit, is what is the exact association, as best as we understand it now? This study tried to look at COVID and the cerebral vascular connection in terms of whether this is an infection or whether this is the immune system response. And I know, you know, that there's still a great deal of uncertainty exactly of how this is playing out. So I would love to hear the panel talk about this.
Dr. Tiwari, you published on this stroke, and you have seen a lot of these patients on the front line back then in March. So go ahead.
So one of the interesting things, Congressman, that we found about the disease was initially it was presenting as what's called large vessel occlusion, which is one of the most dangerous forms of strokes. And but it's those cases when they present to the hospital, we're able to go after them and pull the clot out, doing a procedure called mechanical thrombectomy. And this is how my specific exposure to the disease started. But when we started studying the disease, we realized that the mechanism was not singular. It was not just forming clots. It had 4 different methodologies of causing strokes. One was that it hijacks the immune system and it makes it reacts against the blood vessels. So it makes the platelets aggregate, and the platelets, and in that way, it sort of works like other diseases like lupus or syphilis, where clots form because the blood becomes thick. And in those cases, heparin or Lovenox sort of seem to work. But there were other cases where it went into the heart and causes myocarditis and made the heart slow down enough that it would start forming clots within its membrane. And in certain other situations, it actually made the sort of the layering of the artery or the endothelium of the artery react more strongly, causing sort of small vessel strokes. So it did not follow like one specific pattern. It followed multiple different patterns. And I mean, the classic disease which does this is lupus. And that's what I would say is that the mechanism of cerebrovascular most prominently reflected a response like lupus. However, almost all our studies showed that it's only the cases where certain inflammatory markers are extremely elevated where these strokes happen. We did not find any significant correlation in cases where the inflammatory markers are not high. So we know there's an immune system problem at play, which is causing the issue.
I think in my own mother's case, Dr. Al-Said was involved in almost half of the panel were involved in her care. You saw that there was an acute hypercoagulable state, that these patients start having pulmonary embolism and all types of bleeding. Do you want to elaborate on that? You actually mentioned that in our paper as well.
Well, unfortunately we got to move on because we got to get to paper 6, which is looked at a whole bunch of cases, and it says in essence that it's important for people who are on the front line to consider the not just respiratory, apart from respiratory issues, the neurological issues. And now you have a body of information, and there's always a delay between the information and what happens with frontline care, because you have to make sure that this new information is valid. But given what we know now, is it your sense that in most of the ICUs, that neurological issues are are more in the front line of people's thinking as they go about interacting with patients?
Dr. Al-Said, do you want to take off that?
Absolutely, Congressman. So, again, when this began, we were not sure what we were dealing with. And back in February, March, everyone concentrated on the respiratory problems. First, what's known as ARDS, what's known as the lung damage from an acute severe viral pneumonia. After that, we concentrated on thromboembolic events such as pulmonary embolism, blood clots to the lung. However, with time now, we have noticed a lot more, and at least I have, and I know a lot of my colleagues in the ICU have noticed a lot more issues, especially with neurologic. I mentioned before GI, but now also neurologic issues. With the thromboembolic events, the event rate being higher, in addition to having pulmonary emboli, they can also have strokes, as mentioned multiple times. I've noticed patients with seizures. So now when these patients come in and we're treating them in the ICU with COVID-19, any of these symptoms that arise, any events that arise, such as seizures, such as stroke, we quickly are more able to attribute it to the infection than to blame other causes. So it is, to answer your question directly, it is much more on the forefront of everyone's brains and everyone's thinking. And we're learning a lot more as this evolves. And, I wanted to make a comment also on the delirium portion, which we talked about earlier. Again, I see this a lot in the ICU. With any ICU patient, there's some form of delirium that occurs. The one thing that I've noticed with COVID patients is that it seems to take longer to improve or resolve, even after leaving the ICU. For the majority of my patients previously, after leaving the ICU, after it starts improving on the floor, and then after going home, they improve significantly from their ICU, what's called ICU delirium. I've noticed with COVID-19, this brain fog or this delirium type reaction is taking a lot longer to improve in at least my patient population.
Excellent. So, Dr. Cushing, we also see some limb ischemia and bleeding for creating compartment syndrome and force the orthopedic groups to just amputate the limb. So, your thought on that?
Oh yes, yeah. There's been many cases of severe clotting in the extremity that has led to a need for amputation, which is quite novel as far as my experience with viral conditions. So that certainly unexpected and unique to COVID, it seems, with the extreme clotting events that take place, and the amputee care thereafter is not particularly different than it is for many other types of amputees, but certainly a striking outflow of this disease process.
Well, just today there was a story about whether or not COVID went directly at the central nervous system. I guess the question is it a neurotropic or is the challenges in the CNS really just related to, or mostly related to or contributed by the responses of the immune system, which some of this we've discussed already, but it's raised again, and I want to make sure we get a fair treatment.
Yeah, I think the first thing that's happening in these patients, their olfactory nerve gets involved, and they lose the sense of taste. So, Dr. Eliashiv, your thought from your observation from your cases at UCLA?
I think there is still research on it. I think that there is some neurotrophic as far as the receptors. So I think it's a combination of primary neurological immune mediated factors, which obviously play a role. And I think a lot of those cases are very similar to vasculitis or vasculitis-like pictures from the experience of the patients that I've seen, but it could be multifocal. So in addition to the large vessel, you also see like a lot of small vessel involvement. And you're right that the olfactory symptoms to begin with do support the hypothesis that there are some neurotrophic factors involved in the pathogenesis of the disease. But I think it's more of looking into things in a multifactorial that may involve like both the vascular system, the around in the vicinity of the neurons, the glials, and obviously all the growth factors and interleukins and augmented response, which modulate it. I've seen some patients have like press-like symptoms, posterior reversible encephalopathy symptoms, and hallucinations too,
And some
which
twitching and headaches. Let me ask this question because I want to move to paper 8, which focuses on this study. And the reason why people like you do these studies is to improve the care of the people we know and care and love, and in some cases ourselves. We want to improve their care. This study shares that one of the things that needs to happen is a primary focus on oxygen levels early on as a way of preventing or receding or rehabilitation from neurologic injuries early on in the activities related to patients. And now this was done in October and we're in December, but I wonder whether or not this study has currency among practicing neurosurgeons and neurologists.
Well, Dr. Tiwari, do you want to take that question?
I mean, for most parts, we have not found hyperbaric oxygen or any kind of that therapy to be specifically helpful in cases where the damage has already happened. I do believe that if there is hypoxia during the severe phases of COVID, then it would probably present as hypoxic injury, which can cause cognitive issues and or look like encephalitic syndrome. So in those phases, probably oxygenation in the acute phase may be helpful, but post-acute phase, at least we have not tried any hyperbaric oxygen therapy. Maybe any of the other panelists can speak
How
about it.
about you in rehab center? Do you use hyperbaric chamber? Dr. Cushing?
We may have lost it for a minute. Well, let me just.
I'm sorry, I missed that question. Can you say that one more time?
Do you use hyperbaric chamber as part of rehab protocol?
We are not currently doing any of that. There are some settings that use acute rehabs that use that. I mean, notably, it's VA or Veterans Affairs centers that have that type of resource. But we currently are not using any hyperbaric oxygen.
Well, I'm just talking about paper 9 and 8 are quite similar. But 9 focuses on the rather on not oxygen. And the decrease of it is what is attacking white matter in particular in the brain, and whether that can be reversed in any way based on oxygen levels being focused early on in the process. So, these papers are done by your colleagues. I'm not sure whether they have currency in the everydayness of the work that you do, but I do want you to at least give us some indication about whether you think this is useful or not.
Maybe we can ask from Dr. Rebecca Hendrick and our colleague at the University of Kentucky comment. Rebecca, are you there?
Yes, sorry. Could you repeat that question again too?
Yeah, so the paper is about basically oxygenation of the white matter.
Oh, right. So I don't have experience specifically with patients who've been getting oxygen therapy through the hyperbaric chamber, but certainly in my experience, hypoxia and decreased levels of oxygenation to the brain for whatever reason, whether it's because of COVID or heart failure or any other issues, definitely can lead to long-term and even permanent cognitive deficits with memory, attention, executive functioning, planning.
Excellent.
Well, before we go to questions and answers from the audience, I do want to focus now. Last week, the American Academy for Neurology made a statement. It said that COVID-19 can lead to a broad range of neurological complications, including strokes, seizures, movement disorders, inflammatory diseases, and that this was true even in moderate cases. They called on the research enterprise in the country and actually globally to do more research. And we just had the Healthy Brain Global Initiative call for some 500 million additional dollars for research, because there still seems to be a lot of uncertainty about not just the nature of these neurological challenges related to COVID, but the actual causes and the appropriate therapies and treatment. So the Academy statement, I think in December is this has been a very challenging year, but you see from the earliest days in February from the 24-year-old now to the statement by our most distinguished organization focused on neuroscience, saying that yes, COVID, even in moderate cases, causes neurological complications for a number of people who are infected. And they want more research. So I wanted to have the panel, and if we could have everyone, just kind of say, if you were picking the issue to be the focus of additional research, what would you see it to be? And so we could do a rapid fire, and then we're going to do to get to some intermingling some questions. And I'm going to focus on the last two articles. One is about a doctor here in Philadelphia who's had this issue with being a long haul and brain fog. And another is a 23-year-old Harvard student who unfortunately had a stroke because of COVID. But before we go there, which is towards the end, I'd like to hear what you think should be the priority item for research. And I know, given your different specialties, you may have a different view of what that might be, but I'd like to hear it in rapid fire, Doctor. So if you could orchestrate.
So I think let me just bring a couple of important points that was not discussed overall. First, nutrition is critical in these patients because they quickly lose appetite, and focus should not be only on the medicine. So food is medicine. That's number one thing I want to bring. Number two, we see not only stroke and psychiatric impact. In some cases, we have seen post-COVID-19 cancer. So we have Dr. Yamamoto on the call from the Norris Cancer Center. Vicky, do you want to quickly elaborate on the two important mutations that was reported by also colleagues in Japan?
Oh, yeah.
Yes. Yeah.
Oh, are you talking about that's mRNA? Oh, okay. I think I know. Yes. So the mutation, I think what happened is that this part of spike protein, which is actually the major point where the virus will enter into the our cells as a mode. So it turns out that they find out recently that the part of this particular spike protein has mutated just only one amino acid from D to G that actually caused the virus to become more virulent. So although it seems like this did not actually cause those virus to increase the mortality, but it simply actually increased the how the virus can easily enter into the cells of a human. So it actually increased the infectivity. So this is actually the major cause of a dramatic increase in cases starting from European countries and then into the United States. So that was.
And also, I think there was another mutation that actually allowed the virus to suppress interferon, which is important in innate immunity and generation of fever. So that's why in some of these cases you don't even see fever. With that, I let my colleagues, maybe we start with.
Give me the number one research item that you would request. So, Doctor, yours is to focus on nutrition. All right. Next.
No, ours was focused on overall comprehensive review, and many of the colleagues on this panel on our paper, and we covered everything from vaccine to treatment and nutrition and rehabilitation. And if you have the paper, we'll send it to you again.
Okay, thank you. Let's go in rapid succession through the panel on this question. Research priority.
Okay, Dr. Eliasher, research priority, one sentence.
Yeah. No, one sentence is as sequela. I think there's neurological sequela, there's cardiac sequela. So research into the long-term sequela.
Okay, University of Kentucky colleagues, go ahead.
Hi everyone. My name is Fawad.
You have to speak louder. We can't hear you.
Thank you very much for the Congressman for this opportunity. I'm the PGY board. Can you hear me?
Barely, just one sentence about the future direction of research.
I think that probably developing the biomarker for COVID-19 would be a great road to roadmap towards getting the biomarker.
Thank you. Dr. Hedrick?
I'm obviously biased towards psychiatric symptoms, so I'm very interested in the new onset and exacerbation of depression, anxiety, and other psychiatric illnesses.
Dr. Cushing?
Yeah, I agree with Sequela, kind of the course and the prognosis for these patients that have these conditions and functional restoration thereof. I'm also interested in how to best manage the coagulopathies, the blood clotting disorders that come up with these conditions.
Excellent. Dr. Ashraf Al-Sayek.
Yeah, so rightly so, most of the research has been concentrating on how to treat these patients, how to prevent it with the vaccines. But I think as we are moving forward, I think, in my opinion, looking at long-term complications and how to manage those long-term complications, be it respiratory or neurologic complications, is going to be of utmost importance in the next several years.
Dr. Ambush Tiwari. Go ahead, Dr. Tiwari. You're on mute.
We still don't have any reliable predictors to tell us if how to differentiate between A patient and B patient as to which one will develop the like the vascular or the more severe complication, and which one will continue to have a mild course. And it's very hard to therefore determine if a patient will continue to have a mild course or severe course. And I think reliable predictors would be very significant in sort of determining this in the future.
Excellent. Dr. Bolanos.
Yes, probably one of the research the topics that we have to have is how and why does this virus enter the CNS? Not everybody gets these symptoms, so we are missing that link. Why some people get it, why some people don't get it, and how we can prevent it.
Okay, Dr. Yamamoto.
Well, personally interested in finding some biomarkers to identify who will be most likely will go a severe symptom versus somebody who can recover easily. We still lacking in important biomarkers to tell.
Excellent. So I think the importance of new testing, new imaging, multimodality imaging is also very important in my opinion. Congressman, back to you.
Well, let me ask you a question, just as because one of the challenges for research is to have, the case information, right? So the Infectious Brain Global Neural Network has been doing work out of Liverpool, gathering up cases from around the world. Is this something that I know the CDC and others have been involved? Is this something that gets down at the level of your great institutions that you work at?
Yeah, so we have what's called Neuroscience 20 global initiative that we started with President Obama back in 2014. Summit, and this was actually at that time was focused on some neurological disorders for the world economy and also harmonizing clinical trials and initiatives. So I think along those lines, this is a global issue, and we are afraid that the pandemic of mental illness has just begun, and we really need to break barriers and bring different brain initiatives, different groups together under one kind of a Neuroscience 20 banner, and a lot of collaboration and cooperation on time.
Well, I'd like to work with you on that. We are running a little bit over time. We're going to get some questions in real quick. And we have one question, which is the effort to get people to wear masks. The notion is that, and this is still, I say, some partly debated in the research, but is that the entrance of the virus to the brain is through the nose, is the kind of at least one of the major theories of how this is, how the attack on the brain by the virus takes place. So is it that wearing the mask and covering the nose, is this another message that has been missed in terms of communicating to the public that they can protect their own mental health and their brain functions by wearing a mask? Is the essence of the question.
Well, I think definitely we have missed the opportunity to educate public about the implications and impact of COVID-19 on the neuropsychiatric aspects of individuals. But let's say, Dr. Ashraf Al-Sayed, what is your thoughts in terms of messaging and also mode of entry?
I mean, absolutely, Congressman. So, you know, one of the things is when the population does not have enough information, they become restless and they do not want to follow recommendations. I think you know, wearing masks, covering up, not only wearing masks, that, you know, going out to the grocery store and everywhere else, I see people wearing masks but covering their mouth and not their nose, which doesn't really make sense. So wearing masks, wearing them properly, covering up, you know, any entry point through your nose or mouth will definitely protect or at least decrease the chance of being infected with this virus, directly protecting your lungs and indirectly, and maybe, as you mentioned, even directly protecting the brain as well. Because yes, there is absolutely a connection between your olfactory, your nose, and direct link to the CNS.
Well, it's, you know, look, your brain is, at least as best as I think all of us understand, that's what makes you you. I mean, it's your memories, your thoughts, it's your interaction with your environment is all controlled through your mind. So my point is that as a public health point is, you know, that I don't think we told people that one of the issues at risk is not just, you know, having flu-like symptoms, or, you know, we tell young people that, for instance, case number 12, which is a young man from Harvard, and he's 23. And he says, hey, nobody, this is his quote verbatim. He says, nobody ever told me this. Nobody, you know, when I thought of stroke, I thought of grandpa or grandma. Nobody told me I could have a stroke. He's a rugby athlete. But, you know, now because of COVID, and, you know, we've been communicating to young people that, you know, they are somehow, you know, they're not really at risk, right? Yeah. And so I want to do a couple of things. One is we got some questions in the queue. I want to get to them. I have to thank our sponsor, which is Independence Blue Cross, and you know, for their support for helping us put this on. And I think this is very important. We're going to obviously rebroadcast this on YouTube, and it's broadcasting live on Twitter now. But I do want to get to some questions, and so that we can have you interact directly with the audience. And we're going to take about 10 minutes for that and then wrap up. And this would not have been possible without our great panelists. So I thank you. And if we were together, I'd give you a big hug, but we can't do that. We're socially isolated.
A lot there. Before we go to questions, I just want to make a comment about the topic of heart attack.
Yes.
Come up in Italy, in our colleagues in Iran, and unfortunately one of my colleagues died of heart attack. He was COVID-19 positive, and young neurosurgeon, and just about 3 weeks ago. So it is very important for us to pay attention to stroke and heart attack, and then this type of acute hypercoagulable state.
Well, you know, it's true that we've lost some people in the ranks of neuroscience, and we've had some people seriously injured. I won't mention a name at this point, but we have someone who was very instrumental in leading the neuroscience initiative that I launched out of the White House. He worked on the White House staff. He was a great, I mean, everyday recognized neuroscience in our country who's recovering now from COVID. So this is a real issue for millions of families, and and for people on the front line, it's even more relevant because you put yourself at risk treating those of our family members who get sick from this illness, and we want to thank you for that. But I have to go to some questions from the audience. So one is, I have a young lady who says that she was diagnosed with COVID in March of this year, and she wants to know whether there are plans for studies to monitor patients who've been diagnosed with COVID-19 to further investigate the long-term effects. Now, I know that in Canada, they are now have a study looking at 1,000, what they call long haulers, and they're going to look at them over the next decade. But it'll be interesting to hear from you about other plans that are in the works.
One question. Well, let's go to Dr. Don Eliashev at UCLA, and then maybe Dr. Rebecca Hedrick at Cedars who can comment on their post-COVID care.
I think it's I think it's important to deal with comprehensive care after with these patients. Specifically, I think that I think we don't have enough experience, but I'm expecting to see patients and some with lingering symptoms 6 months later. But it's too early to say how long a lot of those symptoms could linger on, as far as like doing the post-COVID care for these patients. But I am impressed with a lot of plasticity, and as we deal with a lot of the patients that are younger, one of the advantages is that we have a lot more plasticity in the brain that we can deal with.
Dr. Hedrick and Dr. Cushing, your thoughts?
I'm not aware of any specific other studies addressing the long-term consequences, but I would just recommend a lot of the things from the, I think it was the 11th article that talk about ensuring that you're getting healthy sleep, learning something new, being sure to exercise as much as possible, and doing everything you can to maintain social connections. Those are all really crucial ways to improve your long-term recovery.
Thank you, Dr. Cushing.
Likewise, I'd like to echo what Dr. Hedrick was mentioning. I don't know of any specific studies that you of that nature that you mentioned, Congressman, being conducted presently, but I certainly am interested to find out more. And also just we really utilize our skilled therapies, so speech therapy, our physical therapy and occupational therapy services are very vital going forward to helping patients restore as much normalcy to their lives as possible. So we pursue those in the outpatient setting or the home health setting as much as possible for our patients after discharge.
We're going to do two more questions, and the last one I'm going to set up first. I'm the last of the two questions that we're going to do. I'm going to set up first, just so you can have a chance to think about it. But this is a question that's most important for the audience that we're focused on today. And that question is, in terms of the next package of legislation, whether it's it's a building on the CARES Act, and whether it's part of the HEROES Act or whether it's some other name for it, but there's going to be additional funds to deal with the pandemic, and as part thereof, the question of making sure that there are funds provided for long-term studies, right, to track people, is what should Congress be thinking about? As I told you, there have been the Academy's called for this, the Global Healthy Brain Initiative has called for this, but it's very, very important. But I want to go to a question from the audience. This is a question that focuses on, the question is, are environmental and social determinants distinguishable in COVID patients with acute or chronic symptoms for early diagnosis?
So I think there are, as Dr. Ambush Tiwari said, that there are some social and race issues are involved. So, Dr. Tiwari, among your patients in New York, you are hit hard there. Your thoughts on this?
Yeah, at least on the Northeast, when we started our consortium to study these cases, we in fact published the paper, and it came out on a bunch of major news publications also, where we found a significantly higher incidence of ischemic events in the African American ethnicity, specifically in the Midwest and in New York, Boston, and the surrounding areas. So we did not find such a huge correlation with poverty in our population, but we did feel that there was some contribution of sort of zip code analysis, which we did in New York. It's sort of easier to do zip code analysis in New York because it's so dense. So you can sort of map the dense clusters, and a lot of COVID research was mapped along the zip code listing. And we felt that zip code analysis, density of clusters, and general socioeconomic status, specifically tied around, certain communities, we felt that there was a higher predictability of ischemic events in those populations. We're currently studying age, and we intend to study other demographic and ethnographic factors, but so far our research has only been positive with racial studies.
Excellent.
Doctor, can you tell me what you think and other people on the panel could respond too, as the vaccine is introduced, which is, the greatest holiday present I think that the country could receive, and both Pfizer and Moderna and everyone, even those who may not have had all of the success, because it was really the gigantic effort that took place that allowed us to end up with vaccines that actually work. And part of what happens in science is you have to fail sometimes also. So I want to applaud everybody who was in the effort. But this vaccine, how is that in your mind going to affect the near-term interactions around whether people, are more likely to follow your guidance on washing their hands and wearing a mask and socially isolating, or whether they're going to feel more relieved and therefore more reckless?
I think the U.S. government has to put more money into actually marketing and PR on educating the public about what the vaccine is. So the vaccine is not a live virus. This vaccine is a sequence of this protein that can basically make somebody seriously ill. But this sequence is very important in basically it's like a lock and key relationship between cell and the virus. Therefore, this sequence could be a good way of training your immune system to actually attack the virus. And it's also enveloped in a nano particles, so for a better transfer to the cells. So there's no nanobots that are in the public misinformation. So people are trying to attack. So important scientific facts that U.S. NIH and HHS has put up front with CDC to really educate what is in the vaccine. And once they understand that, they can get the vaccine and also Dr. House said, properly wear their mask and follow the rules for a while.
All right, Doctor, let me give everybody a chance to answer that and also to interject their last thoughts. We're going to use this as your opportunity to make concluding comments. And if everybody could try to live within 60 seconds or a minute and a half to do that, it is not out of a lack of appreciation, but we have to conclude our work. There'll be another opportunity in the future for us to be together again. But this is an important session, and we'll make it available on YouTube and through other mechanisms. But let me, Doctor, if you could have the panelists each make concluding remarks and touch on any subject they like.
Sure. Why don't we start from our colleagues from University of Kentucky?
Thank you very much. So with 60 seconds, I think we were primed with the perfect storm of pervasive miseducation about anti-vax and distrust and communication coming from different modalities. Then when we finally got hit with an epidemic, with this pandemic, we didn't know where to turn for consistent information. So unifying the message, providing the science, promoting and clarifying the scientific evidence, being honest and straightforward and transparent about what we do and don't know, solidifying trust in the system and the research, and making that the message to everyone can help boost medical health, mental health, and how we make access to healthcare available to everyone in the future.
Excellent.
Thank you.
Dr. Al-Sayed.
Thank you again, Congressman, for this hour and for today. I think it's going to benefit many people in the future. I agree 100% with the colleagues in Kentucky. I think the main thing is to unify the message coming from the government, from the media, and to maybe less politicize this problem and realize that it's an actual problem. It's not a political problem. It's an actual problem that's killing people out there. And you know, you're absolutely right about the psyche of the population with this vaccine. Many of them, I'm sure, are going to think, once I get this vaccine, that's it, I can go back to normal life. And that is the hope one day, but it just may not be the immediate future in the next couple of months at least, where we still have to keep our guards up, still have to be very vigilant and very cautious of everything that we do, and be very and still promote a little bit of self-isolation through the next at least 6 months.
Thank you.
Dr. Cushing.
Yeah, so my main takeaway is that individual actions do matter. I mean, there's kind of a lot of nihilism that you're seeing, and it doesn't matter anymore what I do, or people are, you know, feel like at this point, you know, behaving however they like to behave is reasonable. But I think, you know, we can all make a difference by wearing our masks, social distancing, washing our hands, doing everything we can to prevent the spread. It's not in my opinion, a political matter. It's simply a matter of what we can all, you know, band together and continue to make good individual decisions to help the future for us here.
Thank you. Dr. Hedrick.
Yes, so I just want to emphasize that a lot of marginalized populations are definitely at risk. I had an 18-year-old woman who had pre-existing heart failure from IV heroin use, who died when she contracted COVID. And so it's just very important for us to work with our patients, our homeless patients, and the patients that have pre-existing complications, and be incredibly vigilant with screening and with educating and making sure that masks are available to everyone.
Excellent. Dr. Tiwari.
I mean, it's a slightly personal message. You know, we as a community have worked together. We've collaborated. We've seen colleagues fall to this. We've seen family members fall to this. So, you know, we really are at the forefront. We've taken care of a lot of people. We're not lying. We're not, you know, saying things which are not happening. And I want the people to have that trust with us as we try to get into this final phase of the pandemic, hopefully, which is not going to continue, but for another 6 months or so, we really need to just put an end to this, like other countries like New Zealand have.
Excellent. Thank you. Good point. I don't know if Dr. Don Elias is still on the call or not. Don, are you there? Okay, we move on to Dr. Vicky Yamamoto. Go ahead.
Yes, it was a great opportunity to speak with all of you, and I really appreciate this opportunity. So, so it is really unfortunate that a lot of misinformation or disinformation about the COVID and the vaccination will spread through media or social media. But at the same time, that means we can utilize, of course, the same social media to disseminate more correct information. So I hope that we will try to disseminate more correct information and importance of vaccine. And then maybe we should probably think about try to create some sort of a public announcement with some kind of a slogan or good short message like get vaccination, protect your body, protect your brain, and so forth. And then there's one thing I would like to also suggest, kind of like a recommendation, is that I really wish to see more hospital to dispatch well-trained neurologists and neurosurgeons to see, check the patients in the COVID ward. So that's something that I would like to share my thoughts about this COVID treatment.
Well, that is an excellent recommendation, and we're going to follow through on that. We definitely need to have more people on the front line who have a absolute knowledge of the neurological challenges that and understand how to interact with patients around those challenges. So thank you.
So, Dr. Bolanos, you are one to the last. I will make a final comment.
Joe is the greatest guy. Joe, I just wanted to say thank you for all you've done. But go right ahead.
Congressman. And I think as an academic exercise, this pandemic actually has shown us that we were not prepared for a pandemic. New emergent technologies actually were not used until as a last resort. And we were still focused on the traditional way of medicine, how it was practiced. Telemedicine was not introduced until mid the pandemic, let's say. So I think we have to be cognizant that we have all this technology now, that we don't have to start from the rudimentary ways that we were treating different pathologies, that we can use this as a first line as well. Also, I think the way to inform the public has been really conflicted. A lot of friends of mine, they just gave up. They were like, I don't believe either the scientists and I don't believe the magicians either, because it's too conflicted. So I think the scientific community has to recognize science doesn't belong to any group, politicians, religious, or whoever. We have to step up and we have to be able to connect to the people and say, well, this is what's going on. This is what you have to do. This is the, without the big words, this is what should be done, so they understand it and they appropriate that message and they want to do it instead of being imposed to them.
Thank you. Thank you. My final comments on this is that we need an organization or organizational structure to fast track therapeutics before pandemics strike. That's why we have a legislation to create a brain technology innovation park as part of the opportunity zones. And I think in the same platform, we have to start educating public about the innovations and technologies that are emerging, like nanotechnology that's being used in this vaccine. And people think this is something like kind of a malware or something. So with that in mind, we want to thank you very much, Congressman, for your amazing contribution to the world of neuroscience and providing us with this platform to present our science.
Well, let me thank you and thank all of the panelists for all that you've done throughout your careers to advance this issue. There's nothing more important to me than neuroscience. I think it's a superior among equals in terms of all of the sciences. And so I've decided that that's where my primary focus is going to be, is try to advance brain research, particularly the public investment in brain research. And I think that, if we're going to spend $1 trillion on a Mars mission, we need to be investing more on understanding the human brain, how the healthy brain functions, and how to deal with neurological and mental challenges, diseases, disorders. We have hundreds and hundreds of diseases and disorders, and we don't have a cure for any of them. Whether it's epilepsy, Alzheimer's, Parkinson's, MS, we go through the laundry list. Autism, bipolar, schizophrenia. We have challenges, and it's not because we don't have great sciences. We just have not made the investment, and we've not been willing to fund enough in order to get to success. In science, you might have to go through 1,000 wrong-headed ideas to find the actual winner. And in the vaccine race is interesting because there were more than 100 different efforts, that were gun-ho around the world on looking for a vaccine. We don't have 100 winners, but we had to be prepared as a society to make all of that investment in order to get to a point where we could have vaccines that could have a positive effect on 90 and 95% of the public. And so we have a lot of work to do. We're going to do it together. I want to thank you. I want to wish everyone a happy holiday. I want to close on another human interest story just to make the point. And I heard this gentleman, Tom Solomon from the CDC, walk through a case of a young woman, African-American, working in a skilled nursing facility who got COVID, never had a psychiatric episode in her life, hasn't had one since, but in this midst of dealing with COVID, she had an episode in which she thought something that wasn't true, and she tried to prevent her kids from being kidnapped when they weren't being a threat of being kidnapped by passing them through a fast food window. And you think about this is the kind of anecdotal story, but it's very, very important because this is not a matter of how COVID affects everyone. It has a different effect on different people and different situations. So, that's why I really appreciate the Kentucky Neuroscience Institute and their willingness to share their case, or the case of the young Japanese young man, 24, and his incident. And I was very impressed with the young man from Harvard who went public with his name and his situation. This talk to, because he can reach other young people and say, look, I'm 23, I'm an athlete, I'm at one of the best universities. Yeah, I never thought I could have a stroke, but I've had one. So the point here is we need to protect people from ever getting to have to be in one of your ICUs. And we can protect them by just saying, let them put their masks on, wash their hands, and let's wait for the vaccine to come as our holiday present. It's going to take a few more months, but we're going to get through this pandemic. So thank you all until we get together again. And I want to thank you all and thank our audience.
Thank you so much.
Thank you.
Holidays. Bye-bye.
Thank you.
Thank you.